Hello, and thank you to Sages and the moderators for the invitation to participate in this session. My name is Arielle Perez, and I'm going to be discussing permanent synthetic mesh from soup to nuts. I have no disclosures. The cure for hernias continues to elude us, and we continue to have patients who present in our surgery clinics with abdominal bulges. In the 2000 New England Journal of Medicine article, Lewandike et al. Published preliminary findings of a randomized controlled trial comparing suture repair to mesh repair. After 3 years, they found that mesh use reduced the incidence of hernia recurrence from 43% to 24%, regardless of the size of hernia. In the subsequent 2004 Annals of Surgery article, Berger, Lewandike, and colleagues published their long-term results of the same study, demonstrating a 10-year cumulative rate of recurrence going from 63% for suture repair down to 32% with the use of mesh. These, along with multiple other studies, have solidified the notion that mesh repair reduces the incidence of hernia recurrence by almost half. On the market today are a plethora of surgical meshes in 3 main categories. Permanent synthetic mesh is the most commonly used prosthetic mesh for hernia repair. It provides a long-term mechanical support to the hernia site. To make an informed decision on mesh, surgeons should know the material it is constructed from and its general structural conformation and textile properties that contribute to the mechanical properties that determine how the mesh will perform once implanted into the patient. Many have been tried, but permanent synthetic mesh is basically made of one of 3 main polymers: polypropylene, polyester, or polytetrafluoroethylene. Polypropylene is a commonly used polymer for everyday products. It's composed of a carbon backbone with methyl and hydrogen groups. It has a high chemical resistance with good mechanical stability, mechanical strength, biocompatibility, and resistance to biologic degradation. As a material, polypropylene has durable strength, it's easy to manufacture, and has a relatively low cost. Common polypropylene meshes on the market include barred mesh and Prolene mesh. Uses for polyester go far beyond great disco outfits. It's a hydrophilic polymer synthesized by a reaction of alcohol and carboxylic acid to form polyethylene terephthalate and was patented in the UK in 1941. It has good biocompatibility, it's extremely strong, it has good durability, and is resistant to most chemicals. Common polyester meshes include Periotex and Versatex mesh. Polytetrafluoroethylene is used in more than just raincoats. Discovered serendipitously at DuPont Laboratories in 1938, it's a synthetic polymer produced by the free radical polymerization of tetrafluoroethylene. With heat and rapid expansion, it can be altered into a strong microporous sheet of mesh, referred to as expanded PTFE or ePTFE. It is this material that has been used in hernia repair since the 1980s. It is a chemically stable product and will not degrade in the body. It is highly hydrophobic, and its microporous nature is often exploited for its ability to reduce intraperitoneal bowel adhesions. Common ePTFE meshes on the market include Gore-Tex mesh and Dulex mesh. The attributes of mesh's structural conformation play a critical role in determining the physical and mechanical properties of permanent synthetic mesh. Material fibers can be arranged in various filament and fiber configurations that determine mechanical properties and handling abilities. Polypropylene is most commonly extruded as a monofilament. Polyester can be formed into a mono or a multifilament, and ePTFE is formed as a patch of fibers. In numerous studies, multifilament fibers have been associated with increased risk of infection due to increased adherence and persistence of bacteria. Fibers are then manufactured into different textile patterns to form mesh sheets, creating complex interlacing 3D structures that impart varying degrees of flexibility. The knitted structure forms space between fibers, creating pores. Pore size has been well studied and plays a primary role in the integration of mesh into the host tissues, affecting collagen formation, repair strength, and infection clearance. Through various studies, it has been shown that larger pores reduce inflammation, fibrosis, and scar bridging, allow for better clearance of infection, induce collagen maturation and tissue ingrowth, leading to increased strength of the repair site. Based on the American Society for Testing and Material, mesh weight is a measurement of the heaviness of the material and measured as the weight per unit area. It is assumed that the thickness of the material is negligible. Mesh weight classification systems are controversial and vary in the literature. Here is a general schema of mesh weights that is used in the 2018 article by Cobb et al. In Plastic and Reconstructive Surgery. Multiple mesh design specifics contribute to the weight of the mesh. In general, though, meshes with reduced material content and larger pores have reduced inflammation and promote improved tissue integration. Anisotropy is the property of a substance like mesh, to show variations in physical properties along different axes. It's often not provided by the manufacturer, but should be considered and evaluated prior to implantation. In the study by Binabozal et al., it can be seen that a stretching force applied on different axes of the same mesh will produce different outcomes, such that a stretching force in one direction elongates the mesh by 26%, while if the stretching force is in the other direction, the mesh elongates by only 5%. In this same study, using an experimental model to evaluate different mesh placements, the authors found that the least amount of mesh slippage and migration occurred when mesh was oriented with the most stretchable axis in the direction of the least overlap, when mesh was placed in a sublay rather than an onlay position, and when mesh had at least 3 centimeters of overlap from the defect. Once inserted into the body, mesh is expected to withstand multiple forces. The maximum stress mesh can withstand prior to tearing or breaking has been measured in a variety of methods and has been published in numerous articles. The lack of standardization with terminology and testing protocols makes data analysis and standalone comparisons between meshes difficult, especially when comparing between studies. Properties of permanent synthetic mesh play a critical role in how mesh performs once implanted into the patient. Let us go over various clinical scenarios and the safety of using permanent synthetic mesh. With a plethora of permanent synthetic meshes on the market, mesh selection should be based on exploiting beneficial mesh properties, while avoiding those that have been shown to be associated with adverse outcomes such as these. Central mesh fracture has been seen more commonly in lightweight meshes. In a retrospective review of a single institution's 255 retromuscular hernia repairs, 2/3 of all recurrences occurred in lightweight mesh cases. When looking at just the polypropylene repairs, lightweight meshes had a statistically significant higher rate of recurrence compared with medium weight meshes. Almost half of all of the lightweight mesh recurrences were found to be due to central mesh fracture. In a retrospective review of another single institution's 36 open retromuscular hernia repairs with lightweight monofilament polyester mesh, Petro et al. Found that at a mean follow-up of 13 months, 22% of patients had recurred. During subsequent hernia repair, they found that 7 of the 8 patients had central mesh fractures. Mesh sensation and pain is influenced by not only the patient and the surgery, but by the type of mesh as well. For ventral hernia repair, in a retrospective, multinational, multi-institution registry review, Groin et al. Looked at 539 open ventral hernia repairs with heavyweight, medium weight, and lightweight meshes. Results showed that heavyweight mesh had the most overall complications. Recurrence rates were similar within all 3 mesh types. However, medium weight mesh had a statistically significant lower rate of superficial surgical site infections and a shorter length of stay. After controlling for surgical location, myofascial release, and preoperative pain with multivariate analysis, patients with lightweight mesh had worse quality of life scores at 6 months and more pain at 1 year. For inguinal hernia repairs, especially open Lichtenstein repairs, lightweight mesh has been shown in multiple studies to cause less foreign body sensation and less chronic pain without any effect on recurrence rate. In 2018, the Hernia Surge Group in their International Guidelines for Groin Hernia Management gave a weak recommendation to the use of lightweight mesh. As a permanent synthetic material implants into the body, there's always a risk of infection. But in this multi-center retrospective review of open ventral hernia repairs in clean contaminated and contaminated fields, Majumdar et al. Evaluated 126 patients with a mean follow-up of 21.5 months. Permanent synthetic mesh was found to be superior to biologic mesh in terms of surgical site events, surgical site infections, and recurrence rates. In evaluation of the mesh and technique, it was noted that the majority of synthetic mesh was a medium weight macroporous polypropylene mesh placed in a retromuscular space. So maybe synthetic mesh is a reasonable choice for most hernia repairs. In the retrospective study of the Danish National Patient Registry by Kokotovic et al., outcomes of over 3,000 elective incisional hernia repairs were analyzed based on surgical technique and mesh type, and 5-year risks of all mesh-related complications requiring subsequent surgery and reoperation for hernia recurrence were assessed. For the entirety of the follow-up duration, the incidence of mesh-related complications continuously increased over time and can be assumed to continue to increase past the 5 years of the study. Mesh should be used with caution. With continued long-term follow-up, the benefits of mesh in reducing hernia recurrence may be superseded by the many other risks that can occur over time. In conclusion, permanent synthetic mesh reduces the chance of hernia recurrence by half. Material and structural properties influence the mesh's mechanical properties and its interactions with host tissues, thus affecting mesh performance. Multifilament fibers increase the risk of infection. Reduced material content and larger pores reduce inflammation and promote improved tissue integration. Mesh should be oriented with the most stretchable axis in the direction of the least overlap. Lightweight mesh should be avoided in ventral hernia repair due to increased risk of central mesh fracture and increased risk of pain, but it should be considered in inguinal hernia repair due to lower rates of pain and foreign body sensation without any difference in risk of recurrence. Monofilament medium weight macroporous mesh, especially when placed in a retromuscular space, allows for tissue ingrowth while reducing chance of infection. There are risks with all mesh during hernia repair. Finding the optimal risk to benefit ratio must be considered during any repair prior to implanting a permanent synthetic mesh. Thank you.